Your body has two organs shaped like beans and the size of a clenched fist. These are your kidneys. March is National Kidney Month and March 10th was World Kidney Day. So it is important to keep reminding ourselves of the importance of looking after these delicate organs. These amazing organs clean your blood, make your urine, control your body's chemical balance, and do much, much more. You simply cannot live without them. Trouble starts when things go wrong and your kidneys start failing. So how can you notice that your kidneys are not working properly? What happens if both kidneys shut down and stop working? Well, stay tuned because these are the issues we tackle in today's show. We focus on kidney failure. Our expert guest will help us understand what kidney disease is, its causes, risk factors, and most importantly, how we can protect our kidneys and prevent disease. We will also learn about kidney dialysis and the kidney transplant procedure. Now, to help us with this is a great team of experts we've assembled for you. This includes a nephrology professor from Wits University, a chief administrator from the South African National Kidney Foundation, a dialysis sister from Helen Joseph Hospital, a kidney transplant coordinator from the same hospital, a patient awaiting kidney transplant, and a kidney recipient. So sit back, relax, and learn from this exciting show ahead. I'm Dr. Salam Mutaou, and this is Health Talk.
There are many causes of chronic kidney disease. The kidneys may be affected by diseases such as diabetes and high blood pressure. Some kidney conditions are inherited. Johan was born normal and lived a healthy life, but what he didn't know was that he had an autoimmune disease which at the age of 29 destroyed his kidneys.
All started quite a while ago. My life history basically, I grew up healthy. What I didn't know is that I was born with an autoimmune disease. But yeah, I carried on a normal life until about 26, which was like a year after I got married. When some symptoms started presenting themselves, I went to the doctor and they picked up that I've got a disease called glomerulonephritis. Basically, it attacks the kidney. The body slowly kills its own organ.
Kidney failure can affect a person's health in several ways. Some people experience fatigue, some lose their appetite, and some have leg cramps. These problems are caused by waste products that build up in the blood, a condition known as uremia. Healthy kidneys remove waste products from the blood. When the kidneys stop working, uremia occurs.
Symptoms pre-dialysis, the symptoms were very masked. I mean, you had headaches, but that was from high blood pressure. You didn't actually know what. I suspect different people experience it differently. In my case, it was just high blood pressure. As soon as that was controlled, look, the corticosteroids gave me lots of energy, so life was great, actually.
It is common for kidney disease to go undetected and untreated in a large number of people. But taking care of kidneys can help prevent kidney disease. Quite often, the things that we neglect to do can lead to kidney disease, such as watching our diet and keeping fit. Detected kidney diseases need to be appropriately and skillfully treated. This demands good medical training, active and relevant medical research, and committed support for kidney sufferers like Johan.
Your friends, it's always quite funny to watch people's reaction actually, because suddenly you're like, this is a dying person, so they're not quite sure how to react and how to handle it. And eventually they say, oh no, you're actually fine, and then, you know what, you can't go on the jawls anymore. you can't drink all hours of the day. It doesn't happen anymore. In fact, on dialysis, your fluid intake should be about 500 mils a day.
Depending on the underlying cause, some types of kidney disease can be treated, often though chronic kidney disease has no cure. In general, treatment consists of measures to help control signs and symptoms, reduce complications and slow progression of the disease. If your kidneys become severely damaged, you may need treatment for end-stage kidney disease.
Now, to help us understand more about this diseases affecting kidneys, let's welcome our guest, Professor Emeritus Anthony Myers. Now, Professor Myers is chairman of the South African National Kidney Foundation. He was head of nephrology and medical aspects of Transplant at Wits University from 1976 to 2001. I might just add that, Professor Myers is the longest living founder of the Kidney Foundation, the Renal Society, and the Transplant Patient Society. Professor Myers, it's an honor to have you on this show, and welcome to Health Talk.
It's an honor to be here as well, Dr. Sala. Thank you.
All right. Let's perhaps start with, I know that we're going to be talking about kidney disease, kidney failure, and transplants and so on. But before we get there, let's just understand what the kidney's normal function is. Why do we need kidneys?
Can I start by giving you a little bit about the anatomy, then you'll see why we need them. The kidneys consist of 1 million filters in each kidney, 1 million in each kidney. And these filters have got little pipes that process the urine that has been formed in the filters before excreting it. Now, if you look at the pipes that come out of these filters, and if you were to stretch them all out and join them from both kidneys, they would stretch from here to Beaufort West.
Gee, that's quite long, isn't it?
And if you cut them open and laid them on their side, they would fit 2 international rugby fields completely. So the kidney's got a huge surface area of work, and the kidney gets 1/4 of the blood volume every second that your body pumps around your body. The brain gets the other 1/4, and the whole of the rest of the body only gets the other half. What does this mean? It means that the kidney has got a huge metabolic job to be done. It needs a lot of blood because it needs to extract oxygen for energy to perform the tasks. So it is a metabolic powerhouse. It doesn't just excrete the waste product of protein metabolism. Sure, that's one of its most important jobs, but it's got a huge other number of functions I think we should just briefly mention.
Right.
Firstly is the water balance of the body. Forget come back to electrolytes, the water. 2 kidneys together make between 160 and 180 liters of urine per day.
Gee.
Most of the good water and stuff comes back into the blood system, having been down the pipes or along the pipes, so that you excrete about 2 liters of waste material. And that takes a huge amount of organization and energy.
Yeah.
Excuse me. The kidneys then also control the electrolyte or chemical balance of sodium and potassium and calcium and other things. Now leave those aside for the time being and come to the other critical issues. The kidney controls the blood pressure.
All right.
And if the blood pressure is not normal, then your heart is affected, all the blood vessels in your body is affected. So it controls the blood pressure via hormonal and chemical methods. The kidney controls the bones, the calcium in our body, the bones that we stand up with. If it wasn't for the many endocrine functions of the calcium, vitamin D, and parathyroid hormone that the kidney controls, we wouldn't be able to stand. We'd be jellyfish.
So no doubt, I mean, these are very vital organs that obviously we cannot live without.
And the kidney makes the chemical that makes your blood. So if you haven't got kidney function, you become anemic.
Right. Okay. Now, I believe that a human being can live without 1 kidney, can live a normal life just with 1 kidney.
Yeah, I think the normal life, you've got to see it in context. If you're born with 1 kidney or you lose 1 kidney at a fairly early age, certainly below the age of 40, the other kidney enlarges both in its size and in its metabolic functions, and you can live with 1 kidney.
All right.
If you're older, you must realize at about the age of 45 to 50, you lose 1% per year of kidney function, even with normal kidneys.
Okay, talking about losing function, perhaps let's move on to now what can go wrong with the kidney. All right. Let's start off by describing, obviously it's a spectrum, and we obviously don't have time to talk about every little thing that can go wrong with the kidney. But just as a spectrum from a simple kidney infection right through to end-stage kidney disease, what can go wrong with the kidney?
I certainly won't start with infection because that's the rarer type. The commonest type, well, first of all, 8% of people with kidney failure have got a congenital or hereditary cause,
Right.
which is not much, but it's 8%. And the commonest is the autosomal dominant polycystic kidneys, where the kidneys enlarge with great big cysts. Then the second lot of diseases in South, I think we must be relevant here. By far and away, the single most common cause of kidney failure is high blood pressure.
Yeah. We're going to come back to the causes and risk factors, but so kidneys can fail.
They can fail
just
with
take
many
us through
diseases.
some of these common definitions now. You know, you have what's called acute renal failure, chronic renal failure, persistent, recurrent, and what have you. Can you perhaps just help us with these?
Acute kidney injury or acute renal failure is something that will put you into kidney failure. You may require dialysis, you may not, but it's recoverable, such as losing blood from a big bleed or accidents or medications, poisoning the kidney, etc. So potentially it's recoverable. Chronic kidney disease is a disease that persists. The world has got about 12, and in South Africa about 15% of everybody in South Africa has got some form of chronic kidney disease, certainly by the age of 50. And that may go on to kidney failure and it may not.
Okay, then how does one notice that in fact there's something wrong with one's kidneys?
I think that's a statement that we're always asked. Don't follow that line. You don't want to notice what kidney failure is. Early on, even without kidney failure, you may have difficulty passing urine, you may have burning, you may have to get up at night, you may have frequency, you may have swelling of the legs. These are rather rare in the whole context of kidney failure. The question to ask is, you must stop that happening. And how do you stop that happening? You stop it by having yourself regularly checked up, especially if you've got a family history of either diabetes or hypertension. The doctor must do a dipsticks on the urine, the doctor must take the blood pressure, and you as the individual must take your own health into your own matters and make sure.
Certainly very important, the question of prevention. We're going to come back to that after the break. We just need to go for a quick commercial break. When we get back, we now understand fully what the causes and risk factors of kidney disease is, and as we discussed, of course, how we can prevent kidney disease. Stay with us.
As stories are broken around the world, SABC makes sure you do not miss out. As the stories unfold throughout the day, News at 8 updates all newsworthy stories worldwide. Globally, we are there. Locally, we leave no story untold. Make a date with News at 8 every Saturday and Sunday on SABC News, Africa's news leader. Vera Ephraim defied family and traditions to follow her dream.
Decided that I'm going to prove to them that they were wrong.
The first breakthrough came in when she was studying and touring in Europe.
That was my first breakthrough.
Generations was her first television debut in South Africa.
It was my first gig. I was very excited. I was very happy. I said, yeah, this is confirmation I'm at the right place.
After pain, rejection, and suffering, her dream became a reality.
I followed my path, and I'm happy, I'm grateful, I'm blessed.
Join your host, Puleng Mulabati, on Bupilong every Friday at 17:30.
A romantic adventure film starring Ivan Buerta and Donnelly Roberts. The story begins in the beautiful vineyards of Paarl in the Western Cape. The adventure takes off when the characters find themselves on the tropical island of Love, Mauritius.
Josephine's work is more interesting and distinguishable. She visits war-stricken zone countries to tell the story of the damage war often leaves behind.
In this particular exhibition's case, places that are named after conflict or disaster or war or reconciliation.
And basically what it is it's a collection of the best animated short films from around the world this year. And the idea is to inspire animators and directors with this exciting content. And so that's been offered to us as a cinema, and we're very excited to be screening the animated show of shows here in South Africa.
Join Rufulwa Mulwa for that 1 hour weekly dose of arts and entertainment news every Friday at 9 p.m. on Trends.
Welcome back. Now, let's find out more about causes, risk factors, and how we can change our lifestyle now to prevent kidney disease. And we continue with our discussion. We still have with us Professor Anthony Myers, and we're now joined by Fanny Dutoy. Fanny is the Chief Administrator at the South African National Kidney Foundation. Welcome to Health Talk.
Thank you very much.
I'm going to come back to you just now. Stay with you, Prof. We were just talking. I think for somebody watching this program would say, hang on, yes, it's important for me to prevent, myself getting to a point where there's now signs of kidney disease. But it's important to then notice that something is wrong with me when you experience those things like difficulty in, passing urine and so on. But let's get back now to perhaps the most important, discussion really, to say, what are the risk factors for kidney disease or kidney failure? And what causes kidney failure?
Risk factors, I think probably the most important, although it's usually put at the end, is your family history.
Right.
If there's a family history of high blood pressure or diabetes, those are major events.
Right.
Other are traditional risk factors such as obesity, overweight, alcohol, and yes, it's not only your heart that suffers from smoking, so do your kidneys. Eating too much carbohydrate, sweet things, too much fat, lack of exercise, sedentary occupation, not getting out into the sun, and stress. These
but you
are
mentioned
traditional.
Family history of diabetes and hypertension.
Yes.
What about if you yourself has hypertension and or diabetes?
Well, let's take you can't talk about them together. Hypertension, don't forget that any kidney disease, if it's chronic, you may have hypertension as a complication of the kidney disease. And on the other hand, essential familial hypertension can cause kidney disease. So I think the point about that is that it doesn't start in adulthood and you get kidney failure at the age of 40 to 70. It starts in children. It starts at the age of as young as 8 and 10. And we've found in South Africa, in the African population, that hypertension is present in school children, pre-anti-matric and matric children at the age of 16, in about 18% of the young men and about 12 to 14% of the young women. That is what you have to remember, and the same with diabetes.
Just now you said you can't talk about hypertension and diabetes together. But surely people that have both hypertension and diabetes are said to be at high risk.
They're even worse.
Of kidney failure. Just explain how.
Well, the diabetes itself causes a disease in these filters, and it scars up the filters with diabetic nephropathy. And diabetes also is far more likely to disturb the regulatory mechanisms controlling the blood pressure from the kidney structure. So it's common to have both together. Diabetes has a serious effect on all the blood vessels of the rest of the body, and so does hypertension. So it's all combined.
Does it matter whether or not they're poorly controlled or well controlled?
Absolutely. If anything is well controlled, you'll either totally avoid kidney failure or you'll delay it and make it much more mild and treatable and prevent the complications.
Yeah. I know that you listed some of them, but let's just focus a lot more on some of those lifestyle issues. You mentioned alcohol, for instance, alcohol abuse. What about drugs?
Drug abuse is a cause of both acute kidney failure and chronic. By the term drugs, I'm not just meaning habitual drugs, but medicines that we take, because the medicines are also excreted by the kidney, a lot of them.
Yeah.
And things such as analgesic and non-steroidals, they are still taken by the bucketful by people in South Africa and elsewhere. And they can cause both acute and often chronic kidney failure. So yes, it's a very big risk factor.
Yeah. What about herbal medicines? I mean, there's huge intake of herbal medicines.
Yes, now herbal medicine as a rule causes an acute kidney failure and very often other organ failure, liver and heart. And if you live, you usually get completely better. But some of the herbal medicines can also cause chronic disease. That's unusual though.
Okay. Perhaps one silly question I need to put to you is, we've understood the functions of the kidney. Is there ever a need to cleanse your kidneys? Because sometimes you walk down the streets, you pick up all sorts of stuff that is supposed to be cleaning your kidneys and that sort of stuff. Is there a need for one to cleanse your kidneys?
The human body is not like a motor car where you have to change the oil. There's not such a thing as cleansing the kidneys.
Right.
You keep your kidneys functioning properly by living a good lifestyle. And if you've got these risk factors, by seeing a doctor regularly to make sure that they're treated early and appropriately.
Okay. Just lastly, trauma. How can it affect kidneys, and what type of trauma?
Well, there's two ways. The first way is the kidneys can be directly affected by trauma. You can have blunt injury with ruptured kidneys and all sorts of problems, arterial bleeds. That's rare because they're right tucked well in the body. But the kidney's affected because you bleed and you lose blood volume, you go into shock. And if the kidneys don't get sufficient oxygen, it damages the structure, the microscopic structure of the kidney, and you get what is known as tubular necrosis. So it stops working temporarily, you have to be treated until this gets better.
Okay, let's cross over to Fanny. Fanny, I introduced you as the Chief Administrator at the South African National Kidney Foundation. Perhaps just tell us briefly what the foundation does.
Well, we're an organization to support patients in the dissemination of information about kidney health. And we have one or two projects that we have running to actually educate the population about kidney health. And one of the biggest projects, of course, is our schools project, where Prof has already mentioned some of the results that we got from the schools project, where we found that 14% of the children actually have high blood pressure. So that's where we go out to schools, we do an educational talk about the kidneys.
Just give us a glimpse of what sort of messages you impart to these youngsters.
Prof touched on it as well, healthy living, which is a very big part of actually educating the youth specifically about taking care of their bodies and the kidneys in particular. And so we do a lot of education around that and sharing information. You mentioned the herbal medicines and things that's available. Telling them that there is no such thing as cleansing the kidneys. That's the basic messages that we would like to get over to the population, because they're being taken for a ride by the media and all that. So
okay. Yeah. So do you only go to schools? What about the adult population?
Well, we have our office where we have available information about kidney health and all that we can share with anybody, and we get phone calls from the public, for instance, to ask about kidney health, and we're always very happy to share information.
What sort of questions, just out of interest, what sort of questions do you field?
Unfortunately, in so many areas of life, people actually react instead of being proactive. And a lot of the calls that we get is about people that's affected by kidney disease to the extent that they actually need to go onto dialysis. And unfortunately, in South Africa, we have very few units where dialysis is offered as a treatment for kidney disease. And people are, they have to go onto a waiting list almost to get onto dialysis. And people that's desperate for the treatment would like to know what they can do and all that. And of course, there's the option that we can always advise them about of not having to go onto dialysis permanently, but trying to get into the transplant program, which is the other option for treating kidney disease.
All right, we're going to talk about that in a few minutes. Okay, after the break, we'll learn more about kidney dialysis, and we speak to a patient on dialysis awaiting a kidney transplant. Please stay with us.
Tonight in an SABC exclusive news expose, we show you how firearm proficiency certificates are fraudulently sold for a few thousand rand.
What you did was illegal. Do you at least acknowledge that? What you did is illegal.
I say it could be probably illegal.
Nigeria is Africa's second largest tomato producer.
The chief executive of Enrisco says he started the company with a capital of $75 million.
The problem now is that the market has been created in China.
He says that doing business in the country is becoming more difficult every day.
Preparing for victory requires intense effort and teamwork. When you get to it, there is no turning back. Because all eyes are on you. When it's action time, nothing should stand in your way. Sports Live tackles and analyzes all the sport action. This is the home of all your sport news, updates and more. Sports Live weekdays at 8:30 p.m.
Controlesa is actually stirring the pot here.
I'm sure they've been consulted as Controlesa. They did not see a snake. Now that in certain areas there are certain benefits that might possibly be accruing, there is a snake, now we need to reverse the process.
I agree, but it is not above the sovereignty of the people. The very same court you're talking about.
The sovereignty of the people, probably you should explain that to me.
The sovereignty of the people is above everything.
It is not proper the way facts are presented to the public. Are you in contact with Khosekgolo Motshodi?
He was kicked out by the court because he wanted to be amicus curiae.
For your weekly dose of all things legal, join Dumile Mateza every Sunday at 2 p.m. only on SABC News Channel.
Suddenly, the autoimmune disease spiked and both my kidneys failed.
Kidney failure happens when kidneys are no longer able to remove waste and maintain fluid balance in the body. When a person is diagnosed with kidney failure, a doctor can recommend dialysis as one of the treatment options. Dialysis keeps your body in balance by removing waste, salt and extra water to prevent them from building up in the body, keeping a safe level of certain chemicals in your blood such as potassium, sodium and bicarbonate, helping to control blood pressure. There are two types of dialysis that a patient can go through: hemodialysis and peritoneal dialysis.
We would look at dialysis as a holding measure, with the actual specific treatment being a kidney transplant. Dialysis should work out. It's a very successful treatment. It's not for everyone, but the life expectancy is much lower than that of a transplant.
Hemodialysis is a procedure done by connecting an artery, usually in the wrist or chest, to allow for blood circulation through the hemodialysis machine. Meanwhile, peritoneal dialysis is a way to remove waste products from your blood when your kidneys can no longer function well. However, in this case, the cleaning of blood is done inside the body, an area in the abdomen called the peritoneal cavity. According to National Kidney Foundation of South Africa, the average waiting time for a new kidney on the donors list is estimated to vary between 6 to 12 years.
I've been on the list 7 or 8 years. My case is slightly more complicated, like Roger explained earlier about suitable donors and my own suitability. So because of the previous transplant, I've got a lot of antibodies. So finding a suitable match is a lot more difficult. But the guys around me on dialysis with me, 3 years, 5 years, we're just not finding suitable donors.
depending on your match, somewhat shorter periods.
Been in dialysis for 6 months, but before I came Morningside, I was at Saningi, and I came to Morningside and the doctor put me on the dialysis. At Saningi, I was not on the list.
Going through dialysis will not cure your kidney disease unless you are able to get a kidney transplant.
Welcome back. If you just joined us, we're discussing kidney disease and kidney failure. And in this segment, we're going to be talking about kidney dialysis. Now, let's understand what this is about from our special guest. We still have with us Prof. Emeritus Anthony Myers, who's chairman of the South African National Kidney Foundation. And we're now joined by Sister Rose Ndobe. Sister Ndobe is a dialysis sister based at Helen Joseph Hospital. Welcome to Health Talk, sister.
Thank you, sir.
Okay. And next to Sister Ndobe, we have Andres Bays. Now, Andres Bays is a patient currently on dialysis and is awaiting a kidney transplant and is said to be in the top 50 list of those people awaiting a kidney. Welcome to Health Talk, Andres.
Thank you.
All right. Perhaps before we go to the patients, Prof, let's get back to you. Just explain to us the principle behind dialysis and the different types of dialysis. What actually is dialysis in simple terms?
Dialysis is an attempt to do what the kidneys do normally. It's very good at excreting waste products and controlling body and acidity, alkalinity, and chemical imbalances. But a lot of the other functions it can't do. It's an artificial means. The first type is what we call hemodialysis, which is a machine to which you're connected. There's a connection into your body that takes blood out of a vein, pushes it through a filter, a bit like your kidney filters, and the fluids are mixed and purified, and the pure blood goes back into another vein higher up the arm. And that happens in chronic dialysis 3 times a week for about 4 hours per session. And that goes on and on lifelong.
Okay.
The other, and then you can adjust the patient's weight as well. You can take fluid off as well. The other type is having a tube implanted. It's a very special silicone rubberized tube that goes into the peritoneum. The peritoneum has got a huge cavity with a big surface area for exchange of fluids. And that stays indwelling, and you put fluids in there and you let them stay there for up to 4 to 6 hours, and then you run them out, and then you do an exchange of fluids, and this can be done at home, whereas the hemodialysis, the patient has to come to the center. Peritoneal or chronic peritoneal dialysis is done in the home, and the patients do it themselves and come once a month to the doctor.
Are there any indications for hemodialysis versus chronic ambulatory peritoneal dialysis, for instance?
The most important indication is to explain to the patient what both procedures are and which ones they would prefer to suit their own lifestyle and wishes. In terms of other things, if somebody hasn't got venous access and there's no way where you can find this connection of blood, then peritoneal dialysis becomes essential. On the other hand, in South Africa, all the hemodialysis slots are usually full, and the peritoneal dialysis may be your only option.
Okay. All right. Perhaps let's understand from somebody who's undergoing dialysis himself, Andres Bays. Andres, please tell us your story. What happened to you? How did it come about that you had kidney failure?
12 years back, I had the symptoms of, like Prof said, also terrible headaches.
Yeah.
And then swelling of the feet. And what I could also see was that difference in my urine was a little bit milky. And then I went to a doctor, and then they diagnosed me.
They diagnosed you with kidney failure?
Yes, he did a blood, he took a blood sample, and then he referred me to Helen Joseph Hospital.
Right.
Yeah.
And when did you start the dialysis process?
Like I said, 12 years back,
Right.
on hemo.
So it was almost immediate. You felt the symptoms.
Yeah,
you went
it
to
was
consult.
almost immediately.
Almost immediately you went on dialysis.
Yeah, on dialysis.
And
yeah.
you've been on dialysis for the last 12 years.
For the last 12 years.
Just
yes.
tell us about how this impacts your lifestyle.
It was in the beginning was very difficult to accept, especially with the family, and with the lifestyle I had, working at a power station as a turbine fitter, and trying to cope with the work and dialysis, and I couldn't anymore. And then thinking of losing your house and whatever, and your family as well, because the children, we used to go out breakfast, like I had that lifestyle, and I had to like everything, you have to change everything for a grant.
Could you continue? So you had to stop working, is that what you're saying?
Stop working, yes.
Right.
Stop working. And then I had to bring my family for counseling as well.
Yeah.
Yeah.
Okay.
And then they couldn't accept. And what made it possible for me is to accept that I've got kidney failure.
Okay. Perhaps let's get to Sister Ndaba. I mean, you're a dialysis sister at the hospital, and you come into contact, as I would imagine, on a daily basis with these patients. Yes. Just take us into your day's work at Helen Joseph Hospital.
Okay. Every day I meet these patients. Now they've become like part of my family.
Right.
If I don't see them on dialysis, I get worried.
Yeah.
What's going on? What happened to the patients? So our patients, they come 3 times a week, 4 hours dialysis session, and then they've got sometimes they do have encounter problems, like in their families, and then when they come, we also intervene by giving them support, and then also send them to the social workers, because it's a multidisciplinary team. We send them to the social workers and then also to the psychologist. So with them, when they face a challenge, like Mr. B said, that they are facing a challenge that they end up not working. Because if you look at how they come 3 times a week, and then 4 hours they be on the machine for dialysis.
But do they have to stop though? Do they have to stop working?
Because of the companies, because we are working in the different companies. I'm in the health sector where they understand the disease, so they will be able to accommodate me. But if I'm working in a company, the manager or the CEO of the company, they don't understand what's going on. When you tell them about the kidney disease, they ask themselves what's going on, what happened to that kidney. They don't understand if you tell them that the patient or that person is no longer passing urine. So they don't understand, and then they have to say no, which means we are no longer going to pay you for these 3 days. And because they're always sick, more especially in an acute phase, when they come, they have to be admitted, they have to go a lot of tests, and then you find that they're unable to go to work. So the managers or the CEO of the companies, they'll tell them, now you have to stop, or we are going to cut off your salary. So that's the problem. They ended up not working. So that's why most of the time we encourage our patient to go for peritoneal dialysis, because in peritoneal dialysis, they'll be able to go back to work. They do their own dialysis at home. We train them. After they've inserted the TENCOF, the silicone that the prof was talking about is the TENCOF. After TENCOF insertion, they go, we train them. We give them health education, we involve the family. And then after that, they go back home, they do their own dialysis.
How many, if you were to look at both those that are on hemodialysis compared to those that are on peritoneal dialysis, what's the percentage split? How many, you know, if you were to estimate, are there more on hemodialysis than peritoneal dialysis, or is it the other way around?
There are more in hemodialysis than peritoneal dialysis. Yeah. Because peritoneal dialysis, when we do a home visit, we check the environment. If the environment is conducive and they don't have a reduced surface area in their peritoneal where they've been gone under surgery, if the surface area is fine and the environment is okay, is conducive, they've got water, sanitation and electricity, we take them to peritoneal dialysis.
Okay. All right. So, just lastly, Mr. Bass, now that you say that you underwent, a difficult period, in the early stages, and you got support, how is it now?
Now it's wonderful with support of my family.
Right.
And then, and I'd like to thank them.
Yeah.
My wife Monica and the 2 daughters.
All right.
And my son that it inspires me a lot.
Okay. Well,
and
I can only wish you well. Let's hope that you get a donor sometime soon. And Sister Ndove, thank you very much for the good work that you're doing. Okay.
Thank you.
We unfortunately have to go for a quick break. After the break, we now learn about the kidney transplant process, and you speak to a kidney recipient this time. Please stay with us.
The big news is Newsroom.
We also stream live on YouTube.
Whether you're at home, at the office, or at the gym, wherever you are, Newsroom is right there with you. Bringing you all the latest news, updates, sports, weather, and everything in between. Get all the latest news you need on the go via live streaming on our YouTube channel. That's Newsroom, weekdays at 9 a.m. only on the SABC News Channel.
Get all the latest news from the SABC's online news services on our website. Breaking news and in-depth coverage of everything from business, sports to politics and lifestyle. Catch the top news clips and watch live streaming of major news events on the SABC News YouTube channel whenever. Stay connected on the SABC News Facebook page and have your say on news that matters to you. And for the latest headlines and live updates from our reporters, follow us on Twitter. SABC Digital News, anytime, anywhere.
Trends follows fashion designers, cultural and lifestyle issues when and as they happen.
I'm always excited to see what the new fresh talent is bringing along. I'm always excited to see the direction that the designers are going in.
We celebrate the brilliant works of playwrighter in Mpumalanga.
When everybody else talk about their own challenges, some talk about maybe the whaling that happens around Japan and other areas, I can be able to say, look, we have been confronted with the problem whereby our rhino population is going down.
We never miss previews of movies locally and abroad just to keep you informed.
So I'm a partner.
Welcome to the big boys.
Join Refulo Mula for that 1 hour weekly dose of arts and entertainment news every Friday at 9 p.m. on Trends.
When a kidney fails, it can have a negative impact on people's lives, but there are several treatment options. A kidney transplant is one of the foremost treatment choices. It is defined as a surgical process where a person with kidney failure receives a new kidney. The kidney transplantation process involves several steps before, during, and after your kidney transplant surgery.
So when we look at matching, we've got to put aside the patient's conception of matching versus what is the medical necessity for matching. So often when a patient talks about a match, they're talking about someone that is tissue compatible.
Kidney donors should meet several health standards for the transplantation to be carried out.
A suitable donor is someone who is actually healthy enough to be able to transplant a kidney to an intended recipient. A compatible donor is someone who has actually passed all the requisite tests to be able to accept that organ from that donor. The public has a misconception, maybe not a misconception, but certainly knowledge that's a little bit old now is about tissue matching. And we all hear about patients saying they want a perfect tissue match. Well, tissue match is from the concept of HLA antigens, and basically in layman's terms, an antigen is a protein that is expressed on a cell surface, and an antibody is a substance that is specific for that antibody. So if we try to bring it to you in an understandable way, we'd say that an antigen is almost like a lock, and the antibody is the key that unfits that lock.
Next concept is about blood matching and achieving blood compatibility between the donor and the recipient.
We have 4 blood groups, A, B, and O. O being the universal donor and AB being the universal recipient. Okay, and I won't bore you with the details, but if you actually are a blood group A, you would need to receive an organ from either someone who is blood group A or blood group O. If you are blood group B, you would need to receive an organ from someone who is blood group B or blood group O. If you are blood group O, you need to receive an organ from someone who is blood group O. And if you are a blood group AB, you are the universal recipient and can receive an organ from anyone.
Research shows that kidney recipients live longer than patients who are on dialysis. A transplant can have a life-changing experience for the recipient.
My life changed after I received the transplant. Now I perform my duties normally, and then I attend sports normally, and then everything's coming normal now. I'm not became absentee at the work, and then I'm a good person now. I don't drink, I don't smoke. I advise people that outside there, they must leave the drinking alcohol, and then they must not smoke because it's affect the kidney.
Welcome back. Now, kidney transplantation is one of the true success stories of modern medicine. If you have kidney failure, a transplant offers the best chance at restoring quality of life almost to a state similar to the period before you got ill. Let's learn more about this from our special guests. We still have with us Prof. Emeritus Anthony Myers, Chairman of the South African National Kidney Foundation and ex-head of nephrology and medical aspects of transplants at Wits University. And joining us is Sister Gwendolyn Cluster. Sister Cluster is transplant coordinator at Helen Joseph Hospital. Welcome to Health Talk, Sister.
Thank you.
All right, and next to Sister Cluster, we have Mr. Aram Tompo, who is a kidney recipient himself. Welcome to Health Talk, Aram.
Thank you.
Right. Perhaps let's start with you. Tell us your story. You're a kidney recipient. When did you get your kidney?
On the 8th of June, 2009.
2009.
Yep, my life changed for the better.
All right. Tell us about that. How did it change? What was your life before and, after?
Hey, I was on hemodialysis, like the sister said. There's a lot of things that you can do because you must consider you have to go and on treatment 3 times a week, 4 hours. And by then, I was using public transport.
Yeah.
So it took forever to get from where I was staying to the hospital, and I had to take the taxi back again. So basically it takes me the entire day.
How long were you on dialysis for?
I was on dialysis for 7 years.
7 years?
Yeah.
And what happened in that 7-year period? Did you have to stop working?
I had to stop working because eventually in companies when you're not productive, because when you're on treatment, sometimes you feel nausea, you don't feel well, your energy levels drop, you feel dizzy, those symptoms, So, companies are just about making money. They don't care as much as the well-being of people.
Yeah. And just out of interest, what did they say the cause of your kidney failure was?
They said it was hypertension.
Okay.
Yeah.
All right. Okay. Sister, perhaps tell us about what you do. I mean, you coordinate transplants. What does that entail?
Yes, I'm a recipient transplant coordinator,
Yeah.
meaning that I'm working with the recipient, the patient that's on dialysis, and the living donors. That's related and non-related living donors.
Okay.
Okay. We are guided by a criteria from the Department of Health. There's inclusive criteria and exclusive criteria. Okay. And the inclusive criteria is basically a patient with a glomerulus filtration rate below 15%.
Yeah.
Patient on dialysis.
Well, let the prof to explain that what that means just now in a while. But anyway, yes. What else?
Patient on dialysis.
Yeah.
HIV patient on ARVs.
Yeah.
For at least 6 months.
Okay.
Exclusive criteria is about patients that has malignancies, cardiovascular diseases, pulmonary pathologies, and psychiatric pathologies.
Okay.
Okay.
Now, obviously, you then have a list of people that are waiting for kidneys, that require kidneys. On the other hand, you have possibly a list of the living donors and what they call cadaver donors. How do you do the match? Who gets on top of the list?
That is a transplant panel at Donald Gordon.
Yeah.
There is also rules and regulations that are set through the transplant panel.
Yeah.
We do blood grouping.
Yeah.
Okay, the blood grouping must be, you got 4 blood groups, okay, AB, or O. AB is the easiest to match.
Yeah. So you kind of have to obviously have a complete match between the donor and the recipient.
Yes.
But Prof, let me get you in here. I mean, this whole notion of some people jump in the list, some people, receiving top priority as compared to others and so on. Is the whole thing completely transparent in both public and the private sector?
No.
Interesting. Why not?
Well, at the moment, there are many understandable, inverted commas, reasons. At the moment, in most parts of the country, you'll have about 4 kidney transplants in the private sector versus 1 in the public, and I'm being generous. And we are told that's because the public sector doesn't come up with donors, and that's true, and there's problems getting donors from our people. The Kidney Foundation is very busy at the moment of solving this, and we have a method that I'm not going to discuss, but I think
but why should it be in the private sector? I mean, is it a question of affordability?
Because the donors come from the private sector. First of all, living donors in the private sector are far more successful because they haven't got the huge incidence of hypertension and diabetes in the younger population that our African population has. So when we look at our living donors in the public sector, a lot of the donors have got disease already, hypertension or diabetes or other diseases where we can't accept them as donors. And in the private sector, that doesn't occur. So there are understandable reasons why the private sector gets more, but with the burden of disease 4 times that in the African population and the Caucasian population, we have got to attend to this, and we have got to get sufficient donors. 15,000 people are killed on our roads every year. That's 30,000 kidneys. Where are they going?
Very interesting. Adam, do you know who your donor was, by the way?
No, apparently they say they couldn't tell us.
They couldn't tell
you? They couldn't tell me, yeah.
Okay. Sister, what is the procedure in this instance? I mean, where you have a living donor, you don't obviously disclose to the recipient as to who the donor was. How do you cancel
you get the altruistic donor, and that person actually wants to give his kidney to anybody. But the donors, the cadaveric donors, we don't disclose to the patient, to the recipient. We never tell them who their donor is.
Yeah. Okay. Prof, let's just get back to you in terms of the procedure now, the transplant procedure. Perhaps just take us through what actually happens.
First of all, to explain to listeners that one of the reasons that transplantation is the name of the game, not just getting a job back, is that it frees up a slot on the dialysis. And in the public sector, there are a very finite matter of dialysis slots, because it costs 300,000 Rand on dialysis per patient per year. That's the total expense. Whereas the transplant's much, much more cheaper. It's 100,000 Rand. And you free up a slot for a new patient to come onto that slot so that they also can get transplanted. What do you do? When you get it, I'm going to talk about a deceased donor now. There's a panel, and you look at your lists and you see who could possibly be a match, and you choose your patient to come in from wherever. They may live a long way away, they may be local. You get the patient to come in and be seen by the medical team to make sure that the donor is fit and isn't in heart failure or has some complication of dialysis. You do all the cross matches and the matching, the HLA typing with the donor. And the HLA typing really is in South Africa shouldn't be priority, because there's a total difference HLA typing in the African population from the Caucasian. So you get a match as best you can. You look at other priorities. Then you prepare the patient for theatre. They are anaesthetized by a highly specialized group of anaesthetists who know what to do with a renal patient. The donor goes to another theatre where the kidneys are taken out. They're washed out with a perfusion liquid. They're cooled down and put in a bucket of ice without blood in, and they can be kept there for a long period of time, up to 20 hours until you do the operation. Yes.
Okay. Any complications, just quickly?
The operative complications are minimum these days. They used to be common when we started, but the complications really, post-operatively, pertain to body rejection of the kidney. That's the most important.
How often does that happen?
It happens probably about 70% minor rejections, but how often it actually harms the kidney, if you look at the 1-year survival of cadaveric transplantation with modern methods, it's over 70%.
So it's quite a successful procedure. Well, here's living proof of the success.
Thank you.
How has it changed your life now?
Basically now, I understand why they call it a gift of life. Now I'm living my life to the fullest.
Great stuff.
I understand the saying that, one day your life will flash before your eyes, make sure it's worth living. So I'm making sure that my life is worth living. I mean, I work now, I can go to the gym, I can travel, I'm studying. Basically, I'm reclaiming my life back. But the thing is, you have to work twice as hard as everybody else to try and reclaim those years. But I think they're past years. But I'm here now, I'm living. I'm awesome. Couldn't be better.
Aram, thank you very much for your contribution. Sister Tlaste, Professor Anthony Myers, thank you so much for your contribution. Unfortunately, we ran out of time. And that's it, folks. And that's how we come to the end of our show today. A reminder to please join us again next week on SABC News, and share your views and comments via our Facebook page, SABC Health Talk, and follow us on Twitter at SABC. You can watch a repeat of today's show and all of our previous shows on our YouTube link. I'm Dr. Seldo McDowell, and thank you so much for watching. Please do take care of those kidneys.